Thank you so much for coming. Can everyone hear me? Yeah, without the mic? We're all right? The business of holding your questions till the end, thank you so much for saying that. This little booklet, the one with the League of Women Voters logo on the front, is the one that would be most helpful to you during the presentation. It follows most of the presentation, and you may feel a little bit of information overload as we go along, but this will remind you what we talked about. And at the very last page, there's a little spot for notes. Jot down a question so you don't forget it, and I will happily answer anything I can. And if I can't answer it, I will get your contact information, I'll find the answer for you, and I'll get it back to you. Okay? So, our topic is healthcare reform after the Supreme Court decision. And good, there's a sweet spot on the projector, so I have to wander around sometimes to get it. As Lee pointed out, the title of the law is not Obamacare, although Obama himself has begun using that, I think. It's the Patient Protection and Affordable Care Act, and that is generally shortened to ACA, or the Affordable Care Act. Your first question might be, why is the League of Women Voters giving talks on the health care law? Most of us are not professional medical people. But we have two related concerns. One of them I know you're familiar with, and that is we want people to vote. We want people to participate in our democracy. That's terribly important. But the second is at least that important, and that is that democracy thrives on the well-informed voter. So that's my job today, to give you some accurate information about the law. I'm not going to try to tell you what you should think about it or feel about it. I just want to be sure that the information you have about it is accurate. So we want to get rid of rumors and misunderstanding and misrepresentation, so that then whatever judgment you make about the law, it's based on fact and not on rumors. I should tell you, the talk I give will not be a comprehensive talk about the law. That's the law. I have read it. Most people haven't, and you may, from comments people make, you may know that they have not read the law. But if you go on the computer and it's there, I'll tell you toward the end where to find it. Don't make the mistake I did of downloading it, because they've got it in large italic print with big wide margins, and it runs over 2,000 pages. And it's very hard to keep track of a stack of 2,000 pages, keep it in order. So, let's begin with the Supreme Court decision in late June. I'm sure you know that 26 of our states in the country sued the federal government over the health care law. They argued that it is unconstitutional in a couple of ways. The way most people heard about this was through the individual mandate. That is, the requirement in the law that any individual who does not have any health insurance and could afford it, that's very important, and could afford it, by 2014 they will be required to buy it, or they will be penalized financially. Okay? Now I might point out that in the healthcare law itself, that individual mandate comes in the section referred to as individual responsibility. So the first decision that the Supreme Court handed down was that the individual mandate or individual responsibility, with the penalty in 2014, if people don't follow through, that is constitutional. Now the law itself argued its constitutionality on the basis of interstate commerce. Healthcare is an interstate affair, and so they argued extensively on that basis. But the Supreme Court didn't. They weren't sure that that really worked well. The Supreme Court decided that it is constitutional because the federal government has the power to levy taxes. And so the fine that people will pay, or the penalty in 2014 if they don't buy insurance, now is categorized as a tax. And it will be taken care of in income taxes. So the IRS will be involved with that. Okay? The second decision handed down by the Supreme Court has gotten a little bit less attention. The law also mandated that in 2014, every state, all 50, are required to expand Medicaid. Medicaid is a health insurance program funded and run jointly by the federal government and the states. And what the law mandated was that the financial eligibility, which had been at the poverty level, which incidentally was different in most states, they could set their own poverty level, the law set a federal poverty level of $10,800. This is 2010. It's gone up a little bit. And what the law argued was that not only from the poverty level down, but 33% above the poverty level. So a total of 133% of the poverty level. Those people should all be eligible for Medicaid as a health insurance program. What that did was raise the eligibility to just under $15,000. I think this year it's just a little bit above $15,000. That's total income for an individual for a year. The idea, anybody making that much money does not have enough money to buy health insurance, and therefore they should be eligible for Medicaid. Okay? The Supreme Court did not have a problem with the extension of Medicaid. What they had a problem with was mandating that every single state had to expand Medicaid. And the penalty, if they didn't, was that they would lose all of the federal funding for their traditional Medicaid. The Supreme Court said that is excessively punitive. So the court didn't say there is no mandate at all to expand Medicaid. What the court said was you can't really force that. And you certainly can't mandate that if people don't do it, they're going to lose all their federal funding on Medicaid in general, the old Medicaid. So what the court said was the expansion of Medicaid is optional. So the states now have a choice, expand it or no. But if you expand it, the law has said the two ways in which you must expand it. One is increasing the eligibility at the financial line. But the other is that Medicaid had been intentionally created to take care of poor children. So the other requirement on Medicaid was no matter what your income, as long as you were low enough, you did not get Medicaid unless you had children. Well, this law changes that. If your income is $15,000 roughly or below, children or no, you should be eligible. Okay? So those are the two Supreme Court decisions handed down in late June. And as we go along, I'll weave a little bit more detail into the rest of the program to see how that has affected things. Well, another question you might have is, why are we reforming our healthcare system? Isn't it the best healthcare system in the world? And the answer to that is yes and no. We have some marvelous medical technology, good medical centers, medical schools, medical research, but not everything in our healthcare system is as good as it should be, given what we're spending. Okay? One piece of evidence for that is this graph. Each one of these little blue diamonds is a country, and it's a country that is sufficiently well developed that they have a decent healthcare system. They have something that would count as a reasonable healthcare system. The numbers across the bottom are the equivalent of US dollars. And they will tell you on position on the graph how much money in US dollars each of those countries is spending on healthcare per person per year. Okay. So you just bring it down and you can find out what each of them is spending approximately in our terms. The vertical axis, those are years, and those represent the average life expectancy in each of those countries. So, let's take an example. I should have brought a pointer. I never think to do that. Well, I don't have one. The lower left corner, that little blue diamond, is Turkey. It represents Turkey. And Turkey spends in the neighborhood of $700, $750 per year per person on health care. And then if you trace it across to the average life expectancy, you'll see they get just a shade above 73 years on average as life expectancy in Turkey. Okay. Now if you go up to the very top, that's Japan, and they're spending in the neighborhood of, say, $2,800 if you bring it all the way down. Got $2,700, $2,800 per year per person on health care. But their life expectancy is just a shadow under 83. So they're spending maybe about 4 times as much as Turkey, but they get 10 years more in life expectancy. So who is this lonesome diamond here? Of course, that's us. We're spending, it has us at about $7,500 per year per person. It's actually closer to $8,000 now. And our life expectancy, when you trace it back across, it's mediocre. We're coming out 5 years better than Turkey, but 5 years worse than Japan. And if you look at the whole cluster, none of those countries are spending anywhere near as much as we are, but all of those countries have a higher life expectancy than we do. So the thought is, in spite of all the money we're spending, we're not getting the long-term good consequences that we should be getting. So something needs to improve. Okay? So that's one piece on the international level. Here we are on the national level. The circle represents our gross national product. And the red piece of pie there is the amount that we as a country are spending of our gross national product on health care. It says 17% now. It's really closer to 18. It's moving up. It's headed for the 20s unless we do something. What that means is that everything else that we need to do as a nation has to take what's left over. So national defense, rebuilding our infrastructure, which is in terrible shape, our educational systems, healthcare research, you name it. Everything else has to take what's left over. And virtually all medical policy people and economists agree that that's not sustainable. We can't keep up doing this. At 17%, it was too much, and it's headed up. So another reason why we need to rethink what we're doing healthcare-wise. And if you notice that last sentence, medical care in this country is the #1 cause of personal bankruptcy. So again, we need to rethink what we're doing. What about Florida? Florida is not doing well. In terms of health insurance, we have more people without health insurance in Florida than the national average. We have fewer employers in Florida who provide health insurance for their workers than the national average. And of course, related to that, fewer workers in Florida have health care through their job than the national average. So health insurance-wise, we're not doing well. We're below the national average. We're going to save questions until the end, if that's okay?
Sure.
Jot it down so you don't forget. How about our taking care of our health in Florida? We're not doing that very well either. We have a tendency in Florida, for whatever reason, to wait until we get sick. And then we go to the doctor, maybe end up in the hospital. And the upshot of all of that is that we are spending our healthcare dollars in Florida at the expensive end. We're not spending them on prevention, on exercise, on seeing the doctor for annual checkups or whatever. We're waiting until it's going to be expensive and frequently very serious. So, as it says here, much of what goes wrong with us could have been prevented, but we're not using the healthcare system wisely. Well, what does the health care law do about any of that? How does it improve our health care situation? The Florida League has picked 5 things, 5 significant things out of the healthcare law, working with a number of experts, both in healthcare policy and in the law itself. I'm going to just list them rather quickly, and then I'll circle back and talk about each one of the 5 in a little bit greater detail. So what is it doing? Notice these are not bragging about accomplishments. This has not been completed. The idea here is this is in the law, and this is what the goals are. This is in process. So what's it doing? Expanding health insurance coverage. It's adding new consumer protections that we did not have before. It's making health care and health insurance more affordable. Strong emphasis on preventive care. 4th, it provides an improvement in quality of the care we're getting. That's contrasted with the simple quantity of things that are done to us. And I'll come back and talk more about that. And then lastly, the law is filled all the way through it with an emphasis on prevention. The Secretary of Health and Human Services, Kathleen Sebelius, put it this way: what we have had until now is really a sick care system. People wait until they get sick and then we try to do something about it. And what we need to do is expand our notion of a healthcare system to the point where we're focusing very heavily on prevention, on trying to keep ourselves well as long as we can, and minimize the need for the development of chronic disease, diabetes, emphysema, all of that sort of thing, and minimize and maybe eliminate the development of some of the critical diseases that develop because we're not taking care of ourselves. So prevention becomes very important all through the law, partly to keep us healthier and happier and more productive and all those good things, but also cut the cost of healthcare. It doesn't cost nearly as much to exercise and find out about good nutrition as it does to spend a week in the hospital. Okay, so let's circle back and look at each one of these in a little bit more detail. When the law was passed in March of 2010, the estimate then was that there were about 40 million uninsured people in the country. That's headed up now toward 50 million. It's in the high 40s, the last I read. The idea, anyway, in the law was that about 32 million of those would be covered by the law. We'll talk a little bit more about how. That meant that about 95% of the eligible legal residents in the country would be getting some kind of health insurance coverage. Now, first rumor that needs to go, I don't know if you've heard it, but I certainly have, there is nothing at all in the law about illegal immigrants. They get no coverage. They're totally outside the law. So if you hear people say, oh, well, you know, this covers all those illegal immigrants, that's just false. Okay? Now, how is it going to cover these people? One thing is the states are required to set up health insurance exchanges. And I'm just going to leave it at that for now, and I'm going to come back when we talk about affordability, and I'll talk more about the exchanges in greater detail. They'll become very important. They know about young adults up to the age of 26 can stay on their parents' health insurance. It had been the case that at 19 they were off. Now they're still there until 26. And notice it doesn't matter if they're married or they aren't, if they live at home or they don't, if they're in school or they're not. None of that is relevant. The only thing that might be relevant, if that young adult has a job and the employer provides affordable health care. And now affordable for the young adult means it does not take more than 8% of his or her income. And if it does take more than that, then they should just stay on their parents' policy. And there are millions of young adults on that right now. They've been thrilled, especially as the economy was not doing well, they've been thrilled to have access to that. Now the next item here for expanding health insurance coverage is Medicaid. And as I mentioned at the start, the expansion of Medicaid was a very important item in the law. The reason, of course, is that if people are making $15,000 or less a year, they cannot afford to spend, what, $5,000, $6,000 on their health insurance premiums. And so they have to be covered by the law in some way. And that's what the expansion of Medicaid was for, to pick up people at the very low income level and be sure that they could be covered with health care insurance. That was to be expanded in 2014, and as you see, the very next line, Florida is one of the states that has opted out, has decided it will not expand its Medicaid program. And we'll talk a little bit more about why and what consequences that's going to have. So Medicaid was to be expanded to pick up probably about 17 million of the 32 million as a goal. About 17 million of those would have been picked up by the expansion of Medicaid across the country. And the last item here, Medicare coverage. Those of you who are on Medicare, if you have very high prescription drug costs, you know about the donut hole. When the Medicare prescription drug bill was passed in, what, 2004? I don't remember the date, but as usual, the federal government did not have enough money to pay for it. That's a real rarity with us, right? The idea was, when you start your prescription drug coverage, for about the first $2,600 of expenses, you would get help. And at about $2,600, you hit the donut hole. And for the next $4,000, you're on your own. You get to pay for those prescription drugs all by yourself. On the far side of the donut hole, when it's up in the $6,000 range, you begin to get help again. That's the donut hole. The goal of the law is to close the donut hole entirely by 2020. Now that date is going to have to be fluid. It's going to depend on how the economy is going. But that's the goal. Close the donut hole entirely by 2020. And I'll come back and talk a little bit about how it's being helped right now. Medicaid. This was to be a very significant portion of picking up people who were uninsured. Florida has close to 4 million uninsured people. We're second in the country with the number of uninsured. Why did we decide not to expand? Well, the people who were putting the law together in 2009, 2010 knew that the economy was in bad shape then. And they surely understood that many of the states would feel they did not have the revenue to pick up Medicaid expansion. So what the law mandated was that for the first 3 years, that's 2014, 15, and 16, the federal government will pay 100% of the cost of the expansion of Medicaid for all the states. So the graph here indicates the amount of the cost that the federal government will pick up, and the little yellow piece of pie is the amount that the states will have to pick up. And not until 2017. Well, you may remember that the governor of Florida said the reason we could not expand Medicaid is that it was going to cost us $1.9 billion a year, all 6 years. So almost $2 billion for 6 years, we couldn't possibly afford it. Well, that's a mistake. I'm not sure where he got that information, but that's false. That's not what it would have cost us. As I just mentioned, the first 3 years, it would cost us not a penny. The federal government picks it up 100%. The last 3 years, the federal government guarantees at least 90%. In fact, not just the last 3 years, but indefinitely. The federal government says it will pay at least 90% of the cost of that expansion. There's a good deal of discussion about this and about whether or not Florida is wise in refusing to expand Medicaid. The Florida Commission on Fiscal and Economic Policy just very recently put out a paper on this saying Florida can't afford not to expand Medicaid because over the 6-year period we're talking about, that's 2014 to 2019, the federal government would pour over $20 billion into Florida to help pay the cost of that expansion. And according to this commission, that would mean about 65,000 jobs. So there's a lot of discussion about whether or not Florida is smart to do this. The point I would make is I don't think this is carved in stone yet. I think the first move was, no, we're not going to do it, and I think it remains to be seen whether we may, by 2014, change that policy. I don't know. The Urban Institute estimates it would cost us, for the whole 6 years, not 1 year at a time, the whole 6 years, between 1.2 and 1.4 billion. And that, they estimate, would be about a 2.8% increase in our Medicaid budget. The Lewin Group, which is a health policy research group, they estimate it would be a 1.1% increase in our Medicaid budget. Okay, so that was the first item, the expansion of health care coverage. The second item on that list of 5 was the law adds new consumer protections. Like what? The first one is already in place, started last year. Your insurance company cannot put a lifetime cap on your benefits. Now, needless to say, we're talking here about essential health care benefits, not necessarily cosmetic surgery or things of that sort, elective sorts of things. But right now, they cannot tell you that you have, $1 million limit on your lifetime benefits. Not so. It's illegal as of last year. Starting in 2014, they will not be able to put an annual limit on your health care benefits. Now that one, the annual limit, there are some exceptions to health policies that were grandfathered into the law. That is to say, they were functioning well before the law was passed. In many cases, if a policy wanted to continue and the clients wanted to stay with it, that policy is grandfathered. And so it's not governed by every bit of the law. And this is one. Some of those policies do not have to put a limit on annual benefits. Now the third, I'm sure you know, that 2014, adults with pre-existing conditions of whatever sort cannot be refused insurance coverage. But the one right after is enormously important. Insurance companies can't turn you down if you have a pre-existing condition, and they cannot charge you higher premiums than your age group or your geographic location. Right now, people with pre-existing conditions can sometimes get insurance, but at an exorbitantly high premium. That will be illegal, 2014. And I should mention, well, 2 things. One is, the one group that can have higher premiums are smokers. Okay, so that's obviously meant to encourage people to stop smoking. But the other thing is, children up to the age of 19 who have pre-existing conditions are currently eligible for insurance. Okay? The adults have to wait until 2014. There is a high-risk pool run by the federal government for people who have pre-existing conditions. It has been a little bit expensive. They reduced the premiums for that this past year. I don't know if they're yet within easy reach of people who have these conditions. 2014, there'll be normal premiums for them. Those two, the accepting pre-existing condition clients and not charging them more, that together is one of the motivations for the individual mandate. Insurance companies are being asked to accept a significant group of new clients who are going to be, for many of them, long-term and expensive. And the insurance companies are saying, okay, we'll do that. Now bring in a group of healthier people who have not been buying insurance bring them in to pay premiums to help cover the cost of the really sick. And this is the standard reason for insurance. With your car insurance, you don't wait until you total the car to buy insurance. You buy it early on. You're paying into the pool so that when and if you need it, the money will be there to help you. You're paying in now to help other people who may need it, and the health insurance psychology is supposed to be like that. Shared risk. Everybody pays in to help pay the very expensive care for the sick. Okay? The last thing, you probably have heard these stories where people have insurance policies, have paid into them for years, they're diagnosed with cancer, whatever, diabetes, and the insurance company finds something wrong with their application and decides that it's really fraudulent, you didn't tell them you had acne when you were an adolescent, and they drop you. Right? That's now illegal already. If you have paid your premiums and you get diagnosed with whatever, your health care policy cannot drop you. So those are some of the consumer protections that you get. Here's another one, and this one is very important because here's another big misunderstanding, and you're seeing it in the campaign ads every day. Your very first protection here is the law protects guaranteed Medicare benefits. And I'm sure you've heard about this $716 billion that's going to be cut, and it's going to take Medicare benefits away. That has been debunked repeatedly, but it's in the campaign ads. Every day you hear it. And it simply is not true. Okay? I'm going to talk a little bit later on about where I think that may have originated, the misunderstanding that may have given rise to the view that that's the law somehow is going to cut your benefits. It is not. It protects your benefits. I should mention, however, that Congress can cut your benefits at any time if you're on Medicare. The law improves Medicare benefits explicitly by providing no-cost preventive services. It gradually closes the donut hole for you. So remind me when we get back to Medicare Advantage, remind me to tell you where I think that misunderstanding may have arisen. I said I would come back to this. We're talking about the affordability of health insurance and health care. One step in that direction is a requirement that every state set up health insurance exchanges. Now, these are much like Travelocity, Expedia, Hotels.com, Kayak, I think is one of the newest ones. That is to say, it will be an internet website. States are going to run these. They set them up and they run them. And what they have to do is pick out a reasonably small but adequate group of insurance companies that serve the state that have the adequate assets and facilities to be picking up a lot of new healthcare insured people. And each of these insurance companies that is approved by the state is supposed to provide a standardized form policy. This is some of the detail the law gets into. That form should not be more than 4 pages. Any insurance policy that you get shouldn't be more than 4 pages. It should be in 12-point print, so that easy to read. And it should be expressed in English that anybody who speaks English and lives in this country should be able to understand. Okay? So no obscure legalese, no fine print. Everything ought to be transparent. People ought to know when they read the policy exactly what they're getting and exactly what it's going to cost. Okay? That's what the exchange is supposed to be. A website where each insurance company is filling out the same sort of form, following the same sort of rules, in order to allow you to do comparison shopping. So you get on the web, and you can look from Blue Cross Blue Shield to Cigna to Aetna to whoever, and you should be able to find out exactly what benefits they'll offer, what deductibles and co-pays, what levels of premiums. The law mandates at least 4 levels in premiums: bronze, silver, gold, and platinum. And of course, bronze is the lowest premium, but that's also the lowest benefit. The bronze level guarantees 60% of your expenses will be covered. And of course, when you get up to the platinum, that's the highest premium, but that guarantees 90% of your costs would be covered. Okay? And all of that, all of the information about that should be on these websites. If you don't use the internet, all of that information should be able to be downloaded to hard copy for you. Or you might go to your library, and I'll talk more about that later. Okay, and the last line, bold, Florida has said it will not set up health insurance exchanges. Okay? We received a $1 million grant several years ago to do this. It's a big job. It's an expensive job, and it's long-term. It's not a little thing you set up a little thing and then go away. It's a long-term proposition, and the previous administration apparently accepted that $1 million, but the current administration sent it back. The fact is, on all of these issues, the current government of Florida objects strenuously to the law. Everything about it. They object in principle. And so anytime money has been offered, they refuse it because they don't want in any way to be indebted to the federal government over the law, or to accept some money and not realize that it's later going to cost them some money. So Florida is opting out every place it has a chance here. Okay, so one of the ideas here is to make comparison shopping for health insurance possible, and the hope is that will make insurance companies compete for your business and bring down the premiums.
Is this for everyone or just on Medicare?
No, the health insurance exchanges are not for Medicare at all. Medicare, you get your insurance almost automatically. Most of us have been paying into it all the time you're working.
So this is for the option insurance you can buy?
This is for individuals who have to buy their own insurance.
Okay.
Well, I'm glad that came up. The basic thrust here is for individuals who will have to buy their own insurance. It allows them to do comparison shopping, get the best deal they can afford. But there is another type of health insurance exchange called the SHOP exchange. And this is geared towards small business. SHOP is Small Business Health Options Program. But it's essentially a health insurance exchange. It will be online. And the idea is this: the large companies, for a long time, have been able to negotiate pretty good premium rates because they have so many employees that are going to buy into the system. And the small businesses have not been able to do that. Insurance companies haven't paid much attention to them. The SHOP exchanges are meant to be for small businesses to be able to negotiate better premiums, even though they have maybe only 15, 25 employees. Okay? So it's meant to be for small businesses, and it will eventually be for businesses up to 99 employees to negotiate a better price for the premiums. The income range between the top of the Medicaid expansion, say roughly $15,000, from there up to about 400% of poverty level, so up to about $44,000. That group in there is not well off by a long shot. They're better off than the Medicaid people, but not terrifically well off. Those people, depending on their circumstances, may be eligible for subsidies from the federal government to help them buy health insurance on the exchanges. Okay. So, I should be sure I finished. No, I jumped the quality here. We talked about the improvement of the quality of care. To make sense of this, it helps to understand that we have for a long time been in a system, and we still are, been in a system that is fee for service. That is to say, every service that a healthcare provider gives you, blood test, x-ray, office visit, any service they provide for you, they charge a fee. And the thinking in the law is that that's worked for a long time, but psychologically speaking, this is not a good motivational program because what it does, it just subtly encourages providing lots of services because that helps the bottom line. And not services that would hurt, but maybe services you don't really need because that brings in more fees to the group. And the idea here is that's really a bad idea psychologically. It's not that, people are criminals across the board. It's just that psychologically it kind of says, well, if I just did a little bit more, we bring in another $100. So the law is trying to move away from that system. And to do that, it's doing a number of things, and they're interrelated. I'm going to focus in this on medical homes. I think a better frame there is medical headquarters. And the law encourages people to get their own primary care physician. Could be internal medicine, could be pediatrics, could be family doctor. But somebody who is going to take care of your health. No matter who else is working with you, this is headquarters. So your doctor decides that you really need to see a cardiologist. Your doctor says, I want you to go see Dr. Smith. And instead of, that big folder of paper about your health care that's been developing over the last 10 or 15 years, there is no way that your primary care doctor can send that to the cardiologist and say, look through this, see what you think. So there's a very strong emphasis on computerizing medical records so that your doctor could then hit a couple of buttons on his computer about things about you that are relevant to having you see a cardiologist, and then he presses the send button to Dr. Smith, and Dr. Smith, a few seconds later, knows you, knows who you are, has the information about you that he or she needs to see you as a cardiologist. So Dr. Smith sees you, has a few tests done, has some test results for that, recommends some procedures, makes a diagnosis, recommends some prescriptions, presses a couple of buttons, hits the send button, all that goes back to your primary care doctor, who can then make all of that available to you so that you know exactly what's going on, and somebody on your healthcare team knows everything that any specialist you see has prescribed, has diagnosed, has recommended, has given tests for, all that coming back to your medical home, your medical headquarters. The idea there gradually is that the people working on your health, your primary care, your cardiologist, your physical therapist, your psychologist, your hospital, any of them, all begin to share the information about you so that they begin to work as a team. They're all working to take care of your health. From whatever vantage point they have a specialization, all that information is being coordinated. It's no longer the case that every specialist does his or her own thing, talks to nobody else about it. The hospital does what they do, talks to nobody else about it. They begin to work as a coordinated team. Now, how about the fee-for-service? Part of being a coordinated team is that they work together and decide what's really wrong with the health of this person. What do we need to do to fix it? How long is that going to take us, and what are we going to do to get there? And how much overall is that going to cost? One bill, and when the check comes in, that gets shared among the team members who have agreed ahead of time how they're going to cut that bill. The idea again is that it isn't how many things can we do for him or her, but rather what does he or she need, how long will it take us, and what is it really going to cost for all of us to be helping. Okay? So that's a move away from fee-for-service toward bundled payments and coordinated care. And the idea there, all of the idea is to see if we can improve the quality of the care you're getting so that you're not getting 2 or 3 doctors who are doing their own thing and maybe in conflict with one another, maybe prescribing medications that are in conflict with one another, maybe repeating unnecessarily tests that one another have already done. So the idea is, let's see what we can do about increasing the quality of the outcome and cutting down on some of the quantity of unnecessary repetition. Okay. So suppose we have better quality care. How would you know it? The idea is that there are teams that have already been set up all over the country of doctors, nurses, insurance people, patients' representatives, evaluating the quality of care that's being provided by individual doctors, by hospitals, by nursing homes, dialysis centers. And the goal ultimately is to put that information online so that you can go to that website in red eventually. I tried it today, I don't think it's up yet. And you can find out. You know, you're going to put grandma in a nursing home. How do I know where they're giving really good quality care? Eventually you should be able to find it on that website. And those evaluations are supposed to be repeated on at least a semi-annual basis, if not more frequently. And that, incidentally, the quality of care being provided will also affect the kind of payments being given to doctors, certainly by Medicare, certainly by insurance companies. If they know the quality of care is really mediocre, the payments are going to be coming down. Okay. The last of the 5 topics that we were talking about was preventive care. And this started with Medicare, but it's expanding out. And here's the idea. If we're going to expand the notion of a healthcare system and move it so it's not just focused on critical care, and move it toward really long-term care for chronic illness, and start it with prevention, with an emphasis on wellness, on how do I keep healthy. How do you get people to do that? Well, you make some of the preventive services free, right? You make them no cost. Things that are no cost are attractive to people, and millions of people have made use of the preventive services available. These are just some of the very early ones that came out from Medicare. An insurance company knows it's a lot cheaper for them long-term to pay for your colonoscopy if they can prevent the development of stage 4 colon cancer, or lung cancer with an x-ray, or breast cancer with a mammogram. The preventive services are far cheaper than the treatment of critical illness. So the insurance company knows, too, it's in their interest. Okay, those are 5 big items in the law. But one big objection to the law is that it's too expensive. We cannot afford it. Well, the Florida League, working with its team of experts, says that we're currently spending $2.5 trillion a year on health care. Surely we ought to be able to do better than that. From the piece of pie out of gross national product, everybody agrees we've got to shrink that piece of pie. Preventive care is one step in that direction. Also, ironically, I guess, the effort to put more people on health insurance is an effort to cut the cost of health care. And you hear a lot of people say, we shouldn't be doing this. Why should we be worrying about getting other people with health insurance? Well, one reason is that people without health insurance, those that could afford health insurance can pay the bill when they have to go to the emergency room. But those that really can't afford it, can't afford to pay the emergency room bill either. And emergency room care is our most expensive form of care. So very often, when the poor are seriously ill, they go to the emergency room and can't pay the bill. And who pays it? Well, sooner or later, the rest of us do. The hospital has to absorb some of that cost, but they recoup some of that cost from the rest of us who have health insurance. When we go to the hospital, our charges will be higher because we're helping to pay for the uninsured. Some of that cost will get passed on to the hospital's insurance company, that will get passed on to the rest of us in increased premiums. Okay? So sooner or later, we all pay for the uninsured. So getting more people insured is in the interest of the hospitals. They're thrilled to have Medicaid expanded because that's going to take a significant number of their emergency room cases and move them into doctors' offices and hospitals. But it's also the case that the rest of us should be glad that insurance coverage is being expanded because that's in everybody's interest. That means we're sharing the cost of health care much more broadly and not just narrowing it on the few people who are willing to pay their own. Okay? So those things are all intended to bring down the cost. Whether or not they will in the long run, don't know. A report from the Congressional Budget Office that was put out in March of this year estimates that the cost will now, if the law is implemented as written, they're looking at a little over $1 trillion. There's more to the law to be enacted, right? 2014 is going to bring a number of other things online, but a good deal of it is already being done. So we'll see if we can beat that $2.5 trillion. The Congressional Budget Office in 2010, when it reviewed the law, looking especially at the cost, the Congressional Budget Office is the nonpartisan watchdog on how Congress spends its money. And they estimated in 2010 that the law, again, if implemented as written, would cut about $124 billion from the federal deficit over 10 years. 2011, they did that study again, and the numbers went up. They estimated that, again, implemented as written, it would cut about $210 billion from the federal deficit over 10 years. The only other one that I have read this year is not that same study, but it's a study of what would happen if the bill is, if the Affordable Care Act is repealed, and the Congressional Budget Office estimates that it would add to the federal deficit over $1 billion over 10 years. So, and here, the hospitals in Florida are, most of them anyway, are very anxious that Florida change its mind and expand Medicaid because that will help the hospitals considerably. Okay. Oh, this is where I want to come back to Medicare Advantage. Are any of you on Medicare Advantage programs? Well, let me tell you, this is where I think that rumor about the cuts to Medicare benefits is really coming from. There are two types of Medicare programs. One is traditional, run and funded by the federal government. The other one is Medicare Advantage. That's run and funded by, mostly funded, by private insurance companies. Okay? There are over 3,000 of those Medicare Advantage programs in the country right now, and they're doing quite well. They expect an increase in enrollment there and a decrease in premiums. They're doing quite well. When traditional Medicare was starting up, the federal government, I think, was a little concerned they might not be able to handle this influx of people into Medicare. So they urged private insurance to get into the business. And the way they did that was by offering them subsidies. That is, for every patient that they would take, the federal government would pay out of Medicare a subsidy to the private insurance company because they were taking Medicare patients. For this year, the average subsidy paid to private insurance for Medicare patients is $1,400 per person. The estimate for this current year, 2012, is that $115 billion is being paid to private insurance companies in subsidies to run Medicare Advantage programs. So, one of the things the law wants to do is bring some of that money, that subsidy money, back into Medicare. This is part of the $716 billion that you keep hearing about that's going to cut Medicare benefits. No, that's not what it's going to do. It's going to reduce the subsidies that go to private insurance companies for Medicare Advantage programs. Well, what are the insurance companies doing with that money? They were encouraged to do a couple of things. lower their premiums for Medicare people, and some of those premiums are like $30 a month. The rest of us pay $99 and up. Another thing they were encouraged to do was give people extra benefits, and they have done that. Not every insurance company, but many. What have they given them? Health club membership, free. Dental care, free. Eye care, free. Hearing care, free. Now, those of you who are on traditional Medicare know that none of those are Medicare benefits. Well, if the federal government, through the law, pulls back on some of the subsidies to private insurance, what's private insurance going to do? They've got at least three options. They can say, okay, we're out of here. We're not taking any more Medicare patients. You're not giving us good subsidies, we're not in the business. That's one thing. Second thing they could say is, well, okay, we'll stay in, but we're going to increase premiums on our Medicare claims. Third thing, and this is where I think the mistaken business has originated, they can say, well, fine, if you're not going to give us full subsidies, then we will cut some of our extra benefits. There won't be any more free health care memberships. We're not going to pay dental care anymore, or we're not going to pay eye care anymore. And people who are in those programs may mistakenly think that those are Medicare benefits. They're not. The rest of us on Medicare don't get any of that. Those are not Medicare benefits. Those are private insurance, frosting on the cake, extra benefits. So when people say you're insured, your Medicare benefits are going to be cut, I think maybe they're mistakenly thinking that my club membership is a Medicare benefit, and if that's taken away, my Medicare benefits are being cut. And that's simply not true. Okay? So nothing that's a genuine Medicare benefit is going to be touched by that $716 billion cut. What they're trying to do is bring that money back into the Medicare program and extend its life. One other thing there I was going to say in relation to that. Well, at any rate, that's the rumor that's going around that's simply false. Okay. Now this is all about the individual mandate. We've talked about that. I should mention, though, that right after the individual responsibility section in the law, now called the individual mandate, right after that is the employer mandate, the employer responsibility. And here's how that goes. Any employer with 200 or more employees is automatically required to provide health insurance for them. 200 or more, automatically. And it looks from statistics as if about 97% of those large companies do that. It's standard. What counts as a small business? That's a little bit mixed when you read it. It's confusing. A small business really is any business that has 99 or fewer employees. But that cuts in three pieces. The large chunk is 99 down to 50, and the next chunk is 49 down to 24. And the very bottom, that 24 or fewer, they get a lot of extra help. Those are very small businesses. Any small business, 49 or fewer, in fact, they are not required to provide health insurance. They simply are not, and they will not be penalized if they don't provide it. Anybody above 50 or above employees, they are required to do something. But now all three of those groups, all the way up to 100, little by little are going to be given access to the shop exchange that I mentioned, the health insurance exchange where small companies can go and try to get some kind of a decent set of premiums for a small group of workers. So anybody up to 99, eventually, they're going to start in 2014 with the very small groups, 25, 24 or fewer really, who have average salaries of around $50,000. Second year, they're going to try to get that next group in up to 50 employees. And then the third year, they're hoping to get those with 99 or fewer. So the idea is gradually help the smaller businesses find ways to buy insurance that are affordable. The penalties, individuals. If you could afford to buy insurance and you're not in one of the groups that is an exception to the rule, and I can mention those in a minute, 2014, your penalty will be $95 or 1% of your income, whichever is larger. And then those numbers will go up each year. They go up a little bit more, obviously to put a little pressure on people to get into the insurance pool. Who's exempted? People in jail, illegal immigrants, Indian tribes. They have their own separate healthcare system. People with religious objections, and they don't specify any group, but I'm thinking probably Christian scientists who object to using the healthcare system. I don't know. That would have to be decided case by case, and the law doesn't specify any groups. And then, of course, people who cannot afford it. People who simply do not earn enough money to be able to buy health insurance. Okay. Florida is not moving forward on any of this. Florida is, the government of Florida is pushing back on the law in all of its forms. But I should say that the healthcare systems in Florida, hospitals, doctors, groups and whatnot, many of them are moving right ahead with healthcare law. So what can you do? You can vote. That's top priority for us. We got this slide from AARP rather late, but if you go to that website, and this is in your little booklet, and you go to the start arrow, it will ask you very generic information, name, age, location, health status, and then it can tell you some of the things about the healthcare law that might be pertinent to you, might be helpful for you. And then, last but not least, this is one of my objections to the way the law has been handled. The most reliable and most complete information about the law is on the internet. And there are a whole lot of people who don't surf the web. And if they want information about the healthcare law, that's the last place they go. But that's the only really reliable place to go. The very first item there, that is the law itself. The second one, Kaiser Family Foundation, I recommend that warmly. It's an enormously well-informed healthcare website. And it has, if you know the internet at all, it has links all over the place. There's hardly a question you can ask that it can't give you information about. So that's an excellent place. The third one, the U.S. government, healthcare.gov, that's the official government website. That also has the entire law in it. It also has places that you can jump off to find out the kind of insurance you might need or want. And then there's one just for Medicare. And then the last two are excellent public policy websites with a heavy focus on healthcare. So I regret that television and magazines and newspapers and whatever have not done a great deal more to publicize the law so that people have accurate information. Whatever judgment they make about it in the long run is a different question, but they should have accurate information about it. My experience in giving these talks, and this is, I'd say 21st or 22nd that I've given, my audiences, by and large, say afterward they had no idea about any of this. I had a young woman in an audience recently come up afterward and say, I had no idea the law had anything to do with me. I thought it was just Medicaid and Medicare. So the lack of information in the general public is a problem, I think. If you don't feel comfortable on the internet yourself, go to your public library. Librarians are terrific about helping you find what you need to find. They'll show you how to get on these websites and help you maneuver and get the answers that you're looking for. So I heartily encourage you to go to the internet and get accurate information.